So we're going to spend the next 30 minutes looking at head and neck, but I'm just going to show you 5 cases first. I want you to have a look at these, and again, no freaking out, okay? We're not allowed to do that in this lecture. We're just going to see if we can learn a little bit about head and neck and see how amazingly cool it actually is. So this is the first case. So first of all, can you see the mass? And do you have an idea of what this might be? What's in your differential for this mass? Okay, the second one. Now this is kind of a more subtle mass to see, but if you can see it, do you know what's causing this mass? What's your differential? Okay, number 3, this is a big one. If you can't see this mass, you might as well leave now. Okay, what do you think this is? This is a real Aunt Minnie, this one. Okay, number 4, again, can't see it, you might as well go. All right, what is this? And what's your differential really? And then our last one. Okay, this is the list of things that we could cover this morning if we're going to do everything you need to know about head and neck in 30 minutes, which could be a little bit ambitious for me to try and do this morning. Everything from the CP angle all the way down to nodal levels in the neck. What are the nodal levels and what's your differential diagnosis if you see a nodal mass? But what I want to start to do, and I usually do this, is a little reality check about the radiology boards. And I'm going to show you all the cases that I got when I came to the US. I did the boards here as well. And I want to show you all the cases that I got in my radiology boards here. That's it, okay? Nothing. Not one head and neck case. And you have to kind of, this is why I want you to take a deep breath and just relax a little for 30 minutes, because the reality is you're very unlikely to get a case. And if you do, you may get one case. You could get a CP angle case, you could get a petrous apex case, you could get a temporal bone case, you could get an orbital case, a nasopharyngeal mass, it could be a congenital lesion, it could be a pediatric tumor, a squamous cell carcinoma, or a nodal mass. You could get one of those 9 lists of things of the different areas of the head and neck that you kind of sort of need to know as a radiologist. And what I want to share this morning is really a way to feel more comfortable with the head and neck. I just want to teach a couple of things that kind of like how you can grasp the head and neck, and how when you're doing your exam and you're in there, how you can deal with a head and neck case if they give you a neck mass. So how to approach the nasty cases. So what we're going to do is just look at these spaces of the head and neck and how we're going to work out what a mass is. So essentially, although there's a lot of detail in the neck, we can actually really simplify it a lot. So the neck is really the pharynx, which is just a tube that for the air and the food to go down, that kind of hangs from the central skull base. And there are 4 neck spaces around it anteriorly and 3 neck spaces around it posteriorly. Each of those spaces that we're going to talk about has specific tissues within it. And therefore, each space has specific pathologies that occur within it. So if you see a neck mass and you can work out which space the neck mass is arising in, you can give a very nice short differential diagnosis just based on knowing which space it is. So that's what we're going to do this morning. So as I said, the pharynx is really just a tube. It hangs down from the skull base, and it really comprises the central aspect of the neck and what we call the pharyngeal mucosal space. It is the home of squamous cell carcinoma, and squamous cell carcinoma is 95% of all tumors in the head and neck, the vast majority. And funnily enough, the reality is they're even unlikely to give you a squamous cell carcinoma in the boards, and yet that is the most common tumor that you'll ever see when you're in private practice or you're in academic neuroradiology. So you have mucosa that lines the pharyngeal mucosal space, and then you have lymphoid tissue as well. And we have small lymphoid tissue everywhere, but we then have the conglomerates, the lingual tonsil at the base of the tongue, the palatine tonsils in the lateral wall, and the nasopharyngeal tonsil in the nasopharynx. So we're going to divide the pharynx, first of all, into different regions. We're going to have, the pharynx into different regions. Behind the nasal cavity is the nasopharynx. It's pretty logical. Behind the oral cavity is the oropharynx, which is just below the nasopharynx. And then the oral cavity, so the anterior 2/3 of the tongue, and then everything to do with the teeth and the inside aspect of the cheeks, the buccal mucosa, that's all oral cavity. The hypopharynx is the connection from the level of the hyoid bone down to the esophagus. And then the larynx is everything from the hyoid bone down to the trachea, okay? And that's how we divide our pharynx into different sections. Now let's look at the spaces around, anteriorly and posteriorly to the pharynx, which is sitting right in the middle of the neck. So we can actually define the different spaces by the layers of deep cervical fascia, which is a true anatomical boundary. You just can't see it on your imaging. But if you know where those layers are, you can actually work out what your spaces are. So there are 3 layers of deep cervical fascia, the superficial, the middle, and the deep. And those 3 layers, either alone or together, are going to divide the neck up into different spaces, and it's going to make it very, very easy for you to look very, very smart when you're reading these scans. So let's start with our first space, our pharyngeal mucosal space that we just talked about. So it's the pharynx. And this is really a muscular tube, but it's completely surrounded by the middle layer of deep cervical fascia. So we can draw it in on our picture, and that is a layer of deep cervical fascia which is outlining where the pharynx is. Then we have our 4 anterior spaces: masticator, parotid, carotid, and parapharyngeal. So the masticator space is defined by the superficial layer of deep cervical fascia, and we can draw that around our muscles of mastication in the axial and in the coronal plane, remembering in the coronal plane that it goes all the way up along the temporalis muscle. We have 4 muscles. We have medial and lateral pterygoid muscle, the lateral pterygoid inserting to the condyle of the mandible and to the disc of the temporomandibular joint. We have our masseter muscle, which is laterally, and then we have our temporalis muscle, which goes all the way up. So if you have a process within the masticator space, it can spread all the way up along the temporalis muscle. So now we have this space. What are the contents of this space? Well, it's kind of straightforward. The masticator space is comprised of muscles, those 4 muscles I just described, the mandible itself, so bone, so any pathology that might arise or go to bone, and then the teeth. And it turns out that the teeth is the most common source of any mass in the masticator space. Dental infection is the most common masticator space mass there is. Now the 3rd division, the mandibular division of the trigeminal nerve, is going to supply this space, and it's going to come down through foramen ovale and supply these muscles of mastication. So let's move back one. We're going to move to the parotid space. This is also defined by the superficial layer of deep cervical fascia. And you notice it comes right up to the skull base. All these spaces sit right below the skull base. So now that we have this defined space, what are its contents? Well, it has salivary tissue, obviously. So you can have inflammatory or neoplastic salivary disease. We have lymph nodes within the parotid gland, not within any of the other salivary glands, but just within the parotid gland, there are lymph nodes, and therefore you can have metastatic disease to those lymph nodes, including lymphoma, or skin squamous cell carcinomas from the scalp can go to these lymph nodes, or you can have lymphoma involving the parotid because it's starting in those lymph nodes. Now the facial nerve, the 7th cranial nerve, is going to run right through that parotid gland, and the reason we want to remember that is because if you have a tumor in the parotid, it can crawl along that facial nerve back into the temporal bone. Okay, let's move to our 3rd space, the carotid space. So this is actually comprised of all three layers, the superficial, the middle, and the deep layer of deep cervical fascia, all combined together to create the carotid space. So what are the contents here? Well, the carotid artery is here with the carotid body right at the bifurcation of the common into the internal and external carotid, the jugular vein, and then the cranial nerves 9 through to 12 run within this space as well. And then there are lymph nodes around it, but they're not within that carotid sheath. Let's move to the next one, and then I want to make another comment about this. Let's come to the last of those anterior neck spaces, and that's the parapharyngeal space. This is also comprised of all 3 layers of deep cervical fascia, and it's this little triangular area of fat in the deep aspect of the face, and it only contains fat. That's it. So it's kind of easy to see on CT because it's going to be low density, and it's easy to see on MR because it's going to be bright on a T1 or an FSC T2 weighted sequence. The magic of the parapharyngeal space is not the pathology that occurs in it, but the pathology that occurs around it. So if you see displacement of our little triangle of parapharyngeal space, the direction of displacement of this parapharyngeal space is going to localize a mass to its space of origin. So a mass occurring within the masticator space is going to push that parapharyngeal space posteromedially. A mass occurring in this deep aspect of the parotid lobe is going to push the fat anteromedially. A mass occurring in the carotid sheath is going to push that fat anterolaterally. And a mass occurring in the pharyngeal mucosal space here is going to push that fat posterolaterally. So that's your key of using the parapharyngeal space. Now I want to just think about those 4 spaces again, because we've talked about the contents. There's muscle, bone and teeth here, salivary tissue nodes and the facial nerve, carotid artery, jugular vein and cranial nerves in the carotid sheath, and mucosa and lymphoid tissue in the pharyngeal mucosal space, and just fat here. So you notice that each of these spaces has entirely different anatomy within it, and therefore it's going to have entirely different pathological processes, which means your differential diagnosis is going to be very different just by localizing which space the process is occurring in. So let's move to our posterior neck spaces before we look at some great examples of all of these. So we have the perivertebral space, the retropharyngeal space, and the posterior cervical space. So the perivertebral space is nicely defined by a very thick layer of the deep cervical fascia, which is the deep layer of deep cervical fascia. And this is actually very easy for the surgeons to see. They call this the carpet when they come down to it in a dissection. But it goes around our prevertebral muscles, our longest colli and longest capitis muscles, and then it goes around the paraspinous muscles. So what are the contents of this space? Well, obviously the vertebral bodies, and that means also the discs between the vertebral bodies, the paraspinous and prevertebral muscles, and then the nerves are going to emerge laterally. And in fact, the brachial plexus gets a sheath of this deep layer of deep cervical fascia around it as it emerges out laterally in the neck. So the sort of pathology we might expect to see in the perivertebral space is going to be pathology coming from the vertebral bodies, so metastatic disease, or from the disc spaces, discitis, osteomyelitis, or potentially maybe some sarcomas, but incredibly rare. But you can see the pathology here is pretty limited of what is going to occur in this space. Let's move to the retropharyngeal space, which is anterior to that. So remember that the layer of fascia, the middle layer of deep cervical fascia around the pharynx, and then we just talked about that deep layer of deep cervical fascia anterior to the muscles. There are also some little lateral sleeves called the alar fascia. And the retropharyngeal space is this space between those layers, the middle layer and deep cervical fascia. So as you get up high, close to the skull base, it's very hard to see this space, and it's more of a potential space. It only contains fat and lymph nodes, and this is where the retropharyngeal nodes reside. Now, if you notice the shape of this, see how you have this lateral V? So the lateral retropharyngeal lymph nodes actually sit right back in this kind of V contour where the alar fascia meets the deep layer of deep cervical fascia. And so on your images, it kind of looks like retropharyngeal nodes are medial to the carotid artery. And so they're really sitting back in this V, but here's our carotid. So those round nodules medial to the carotid are always retropharyngeal lymph nodes. So we're going to finish with the posterior cervical space, which is really the posterior triangle. And it's just that fatty space down the posterior aspect of the neck between the sternocleidomastoid muscle and the paraspinous muscles. There are lymph nodes in here, and they typically are draining scalp lesions. So posterior scalp lesions drain here, or lymphoma loves the posterior cervical space. There is fat here, and then the spinal accessory nerve runs through this space as well. Okay, so now we've defined our deep spaces of the head and neck. We have the pharynx centrally. We have the 4 anterior spaces, the masticator, parotid, carotid, and parapharyngeal space. Remembering that parapharyngeal is just fat. There's very little else in there. This is a little bit of the pterygoid venous plexus, gives us these dots within it. We then have the retropharyngeal space, the perivertebral, and the posterior cervical space in the posterior aspect of the neck. So now that you have your 8 major spaces, and you kind of understand a very basic idea of what the anatomy is, when you see a mass, what you're going to do is first determine which space the mass is in. If you know which space it's in, think about what are the normal contents of this space. Is it muscles? Is it salivary tissue? Do lymph nodes occur here? Are there vessels here? And once you know what the contents are, you then just use your radiology analysis of, does this look aggressive? Does this look well-defined and benign? And then you form a differential diagnosis. Okay, so let's look at some cases, but of course there's always an exception to every rule, and this is the important exception to be aware of because it does help you a lot. So while most masses will conform to those spaces, those deep layer of the layers of the deep cervical fascia, there are some lesions that will not conform to those spaces. And they're really of 2 flavors. They're either lesions that developed before the fascia was complete, so they're congenital lesions, or they are aggressive lesions that are actually going through the fascial layers. So in other words, they're either malignant processes or they're aggressive infections that are going through the layers of deep cervical fascia. So it actually does help you. The exceptions actually help you a lot with understanding the pathology. So let's start with some cases and see if we can use those rules to understand what's going on in the head and neck. So this is an axial T1 weighted image and a coronal post-contrast T1 weighted image. And in the head and neck, certainly at UCSF and in many institutions, we always use FATSAT post-contrast, and we always use FATSAT on our T2 weighted images to really look at our pathology. We can see a soft tissue mass. So where are we? Well, we're right in the middle of the neck, so we've got to be in the pharyngeal mucosal space, okay? Now we're at the level of the nasal cavity, so the part of the pharynx at the level of the nasal cavity is the nasopharynx. So we know we've got a nasopharyngeal mass. It's a mass arising from the mucosa of the nasopharynx, and then it's spreading out into that parapharyngeal fat. Here's the normal parapharyngeal fat on the contralateral side, and involving this muscle, which is the lateral pterygoid muscle. On the coronal, you can see how extensive this mass is. So we know we're in the pharyngeal mucosal space. We have a mass that is starting here, but it's going out into the parapharyngeal fat and into the muscle, so it's either a congenital lesion or it's an aggressive lesion. So what arises? What tissues do we have in the pharyngeal mucosal space? Well, we have mucosa, and I've already said that squamous cell carcinoma is the most common tumor, so you're going to put that pretty high on your list. The second thing is lymphoid tissue, and you can get lymphomas here. So your differential for this mass is really, this is a pharyngeal mucosal space lesion in the nasopharynx. This is either going to be a nasopharyngeal carcinoma or it's going to be a lymphoma, and that's your differential. This is the T2 weighted images, again showing how aggressive this is, and this is a nasopharyngeal carcinoma. But your differential is extremely short. That's working? All right, let's move on to another case. One of the key things to remember of any of these masses, all of those spaces abut the skull base. So in every case, you want to look up and see if there is destruction of the skull base or invasion, as in this case, through foramen ovale intracranially, which makes this a T4 tumor. Okay, that was unknown case number one. All right, let's look at another case. Where is the mass, first of all? Well, I can see nice parapharyngeal fat here. I can see parapharyngeal fat pushed medially here, not interrupted, just pushed medially. And I can see a low density mass in what looks like it should be a medial pterygoid. If I look on the other side, you can see this is medial pterygoid muscle, normal density. Here is a low density mass in the medial pterygoid muscle. So we must be in the masticator space. So masticator space contains muscles, bones, and teeth, and is supplied by the third division of the fifth cranial nerve. Now, I already gave this away at the beginning. I told you the most common mass you're going to see in the masticator space is related to the teeth, is dental infection. So you always want to get a bone algorithm and look, oh, this patient has recently had both third molars removed, and this is a masticator space dental abscess from infection occurring in a removed molar. And they typically are in patients who've had a molar removed. It's not typically in patients who actually have active infection occurring in a tooth that's intact. It's usually after removal. And this is a dental abscess. Notice on the post-contrast, you don't get nice rim enhancement. And in many head and neck abscesses, do not expect to see a beautiful enhancing rim like you do in brain abscesses or like you do in things like liver abscesses. They typically will not have a well-defined enhancing margin. But this is a dental abscess, the most common masticator space mass that you'll see, and always ask to see the bone algorithm to look at the teeth. Let's look at this mass then. We have a very heterogeneous mass. You can see it kind of looks pretty aggressive to me because it looks like it started, well, we're in the lateral face. If we look on the contralateral side, there's masticator space muscles here. So it probably also started in the masticator space. Let's come to the coronal. Here's our lateral medial pterygoid. Yep, this has to have started in the masticator space on this side. It's kind of big and aggressive and enveloping everything. And this is a pediatric scan. Now many of you can probably tell from looking at this that it looks like the face of a kid. But if not, ask for the age and the age of the child, sorry. Don't ask for the name. That's a little HIPAA violation. This is clearly a masticator space mass. It looks aggressive, and you've got a pediatric patient. So what could be here? Well, this doesn't look like an abscess here. Okay, we don't really have a fluid density mass here. We've got a solid, aggressive mass. So it could be something arising in the bone, a sarcoma arising in the mandible, a Ewing's potentially, or an osteosarcoma, or it's a mass arising within the muscles. And the pediatric age group, the most common malignancy arising in the head and neck is going to be a rhabdomyosarcoma, and that is what this child has. So you know it's in the masticator space. You have a very short differential of either a sarcoma from the mandible or a sarcoma from the muscles. And that's how you work this case out. This is a rhabdo. The next case we're going to move to, you can again see asymmetry in the neck, and you can see a soft tissue mass in the right side of the neck, intimately related to the jugular vein and the carotid, the internal and external carotid arteries pushed, separating the jugular from the carotids. It's enhancing a little, but it's not enhancing a lot. But you know this is in the carotid space. What are our contents of our carotid space? Carotid artery, jugular vein, and nerves. So the first question is, could this be a carotid pseudoaneurysm? It's not really enhancing for that. You know it's not a thrombosed jugular vein because you can see the jugular vein quite nicely. So you're left with nerves. And so this is most likely a nerve sheath tumor. Nerve sheath tumors come in two flavors, schwannomas or neurofibromas. You would be correct if you just said this is probably a nerve sheath tumor because it's a solid mass within the carotid space. But in fact on CT, neurofibromas tend not to enhance a lot on CT. They will on MR but not on CT. And so this is a neurofibroma. If you said it's a nerve sheath tumor, you're correct. Another carotid space mass intimately related to the vessels, but notice on this one, unbelievably intense enhancement on the CT scan, incredible enhancement and little nodules around it. This is a carotid body tumor, markedly hypervascular, lots of vessels supplying it. If you get nice fancy 3Ds, the key thing you're looking for is this splaying of the internal and external carotid artery to indicate that this carotid body tumor arose exactly at the bifurcation and pushes them apart. Okay, that's the key finding on your imaging you're looking for. So I think it is entirely reasonable to ask if they have a reformat. If you're having trouble working out if the internal and external are splayed, that's what you need, is a reformat to see it. Let's move on to the next case. Well, we can see a mass, a low signal intensity on T1, very high signal on T2, fat-saturated images. Where is this mass? Well, if you look on the other side, this is a normal parotid gland, so this looks like this is entirely within the parotid. So this is a parotid space mass. On the coronal, we can see it again, low signal intensity on T1 weighted images. So we have a parotid space mass. What's our differential? Well, we have parotid salivary tissue within the parotid space, we have lymph nodes within the parotid gland, and we have the seventh cranial nerve passing through it. So this could be either a parotid inflammatory lesion. Well, there's no inflammation around the parotid tissue. It could be a parotid neoplasm, and what's the most common parotid neoplasm? A benign mixed tumor, pleomorphic adenoma. 90% of them are going to be a pleomorphic adenoma. You want it to be very well defined to call it a pleomorphic adenoma, and you want it to be bright on T2, just like this lesion is. Could this be a malignant parotid lesion? It could be a malignant parotid lesion, and it's in your differential. You're going to say it has features that are consistent with a pleomorphic adenoma, but I would recommend FNA. This really does look like a pleomorphic adenoma, and that's what it turned out to be pathologically, but all of these lesions will get biopsied and removed. Your differential is really a benign lesion, a pleomorphic adenoma, a malignant, but very well defined, therefore low-grade malignant parotid lesion. Possibly lymph node disease, but it's pretty large. But yes, I've seen a Hodgkin lymphoma look like this in a parotid gland, but it's a differential. Just to contrast it, this is one of the unknowns I gave you. You see this huge mass down here, pushing the parapharyngeal fat medially in this case and anteriorly. If you look at the lateral aspect, it's contiguous with the parotid gland. So this is a mass arising in the deep lobe of the parotid and pushing that parapharyngeal fat anteromedially, and you can see it around it. It's very well defined. It's very neat and tidy, this deep lobe of parotid mass. So it's got some features that suggest it might be benign. Here it is on T2, beautifully well-defined mass on T2, and I love T2 for looking at the margins of a parotid lesion. What's the most common parotid mass? A pleomorphic adenoma. And this is a pleomorphic adenoma of the deep lobe of the parotid. Characteristic appearance, these grow very large before they present. This is an Aunt Minnie. The key to remember is on contrast enhanced images, and this is the image I gave you at the beginning, they look awful. And many people describe these as appearing necrotic on post-contrast images. It is not necrosis, it is the heterogeneous nature of these tumors. The T2 is the key. This is very well defined, very bright on T2. This is characteristic for a pleomorphic adenoma. That was unknown number 3. Okay, let's cover the posterior 3 spaces fairly quickly. Where is this mass? This is the trick one because it's so symmetric it's hard to see. But you notice you cannot see prevertebral muscles here. They're enveloped by whatever this process is that's pushing the pharynx anteriorly. So this is a perivertebral space process. Remember, there's muscles in the perivertebral space, there's bones and discs. So you need to look always at your bone algorithm, and this is a discitis resulting in perivertebral infection. And the next thing you're going to do with this case is look back and make sure that there is not posterior spread back to compress the cord in these cases. But this is discitis osteomyelitis with perivertebral spread, prevertebral abscess. That was unknown case number 2. When you have something in the retropharynx, you cannot distinguish it on a lateral plane film from a prevertebral process. You need cross-sectional imaging to tell you if it's a retropharyngeal or a prevertebral process. This is a retropharyngeal space mass, and it's kind of a tricky one, but remember I said when you get rounded masses next to the internal carotid, medial to the internal carotid, they're retropharyngeal nodes. And this is a suppurative lymph node in the retropharyngeal space, a lot of inflammation around it, and look how that internal carotid artery is in spasm related to it. Posterior cervical space, you have 2 flavors here. You've got congenital lesions, cystic hygromas, love the posterior cervical space, well-defined, no enhancement of the rim, fluid density mass, just pushing everything out of the way. This is a congenital cystic hygroma. And your differential for posterior, this is our unknown number 5, for posterior cervical space mass is cystic hygroma or lymph nodes in the neck. And I said at the beginning, when you see lymph nodes here, it's either lymphoma, as it is in this case, in the posterior cervical space, filling up that fat, or they're squamous cell carcinoma mets from scalp tumors from the posterior coming down to the posterior triangle. And this was lymphoma in this case. Just quickly, multispatial masses, this is another congenital lesion. When multiple spaces are involved, it's either congenital or it's aggressive. This is a congenital multilocular lymphatic malformation, a type of cystic hygroma, but multiloculated. So multispaces, congenital, aggressive. Okay, it's your 2 grouping. And this is a parotid carcinoma started in the parotid, invading the masticator space. So this is not a benign pleomorphic adenoma in this case. This is too aggressive, and this has got to be a parotid carcinoma, needs an FNA and resection.